right, we'll give it another minute, and we'll get started. All right, well, thank you so much, everybody, for joining us for our the next session of the PHOP lecture series. Today, I'm excited to introduce Alan Ratliff and Anika Grover. Alan is a clinical social worker who's on the front lines of the homeless epidemic. And as a doctoral candidate at the school, this Berkeley School of Social Welfare, his research has been focused around young adults experiencing homelessness, primarily queer and transgender youth. Anika is an undergraduate student pursuing her degree in public health. She's one of the directors of the Berkeley Suitcase Clinic. Her long-term goals include obtaining her medical degree and continuing her work with the underserved as an informed street-level physician. And both of these individuals are members of Berkeley's Catalyst Group to End Youth Homelessness. And so without further ado, please help me welcome Alan and Anika.
Thank you. We are excited to be here today. So our talk today is entitled Gender Sensitivity in Healthcare and Services for Young People Experiencing Homelessness. We're gonna talk a little bit about gender, we're gonna talk a little bit about youth homelessness, and we're gonna talk a little bit about services. First, I wanted to give you a quick introduction to us. Like Malcolm said, I'm a doctoral candidate in the School of Social Welfare at UC Berkeley. My background is in clinical social work. I'm a licensed clinical social worker. And I've been working with young people experiencing homelessness for about 15 years now. And I've also spent a lot of time working with queer and transgender young people. My dissertation research, which I'm currently in the last stages of finishing my dissertation, is about the life history experiences of young transgender people and how early life violence might impact their development. I'm excited today to be joined by my wonderful colleague, Anika. Anika, you want to introduce yourself?
Sure, yes. Thank you so much. Hi, everyone. It's so nice to be here. My name is Anika. I use the she, her pronouns. And as Malcolm mentioned, I am a senior at UC Berkeley studying public health. During my time at Berkeley, I've just been incredibly blessed to have fallen into work with this incredible community of people and have found my passion working specifically with families and children experiencing homelessness and extreme poverty. I'm so happy to be here today, and just to start off, wanted to give you a little bit of a brief introduction into who we are as the Suitcase Clinic and our positionality for being here today. So as you can see on the slide, our mission at the clinic is to promote the health and overall well-being of underserved individuals through service provision, cooperative learning, and collective action among community and professional volunteers, students, and participants. So that's a whole lot of words, but really what it boils down to is that we believe in the dignity of all human beings and hold that healthcare and housing are basic human rights for all people. And next slide, please, Alan. Great. So as a Suitcase Clinic, we operate 3 separate clinic spaces. And now just this, take it with a grain of salt, has all really been changed due to the global pandemic that our world has seen. But in non-COVID times, we were operating weekly clinic spaces, 3 of them to be exact, that all offered some pretty overarching services. So we all offered undergraduate services, including a warm meal, foot washing, hair cutting, blood pressure management, distribution of healthcare resources, but we also offered a variety of professional services that we offered with the help of our amazing community volunteers who would provide things such as legal support to our clients. We even had partners from the Touro University University providing OMM support to our clients, with I know a lot of y'all will be very familiar with. We would provide podiatry support, chiropractic support, acupuncture, really just a variety of wonderful resources that we got to offer with the aid of our community volunteers. And the reason why we offer 3 separate clinic spaces for folks to come and visit in Berkeley is because we recognize, I'm going to get into this a little bit more through this talk today, that experiencing homelessness and the experiences of folks experiencing homelessness are incredibly intersectional. There's not just one blanket statement that can cover everyone who is experiencing homelessness, and homelessness doesn't look like one thing. And so to really try and do our best to recognize that, we have these 3 separate spaces that people can go to depending on where they feel most comfortable. So we have our YQT Plus clinic, which is for youth and LGBTQ plus individuals, as a safe space there. We have our women's and children's clinic, where I am lucky to be a director, where we have female identifying individuals and their children coming. And we have a general clinic open once a week that's open to anyone and everyone in the community. Next slide, please. Yeah, and just to briefly kind of explain what has happened since our worlds were all turned upside down with COVID, was we opened up what we call our grab and go clinics. So we did not want to stop completely, but we also knew that operating that we were before was not going to work. We could not keep gathering for the week. We could not sing, laugh, share stories. All of that had to be put on hold. But what we just figured was we needed to keep getting resources out there, and we needed people to know that we were there. So all our 3 clinic spaces bubbled up our volunteers into social bubbles. You would volunteer with the same group once a month. We offered a variety of grab and go resources. So we would essentially just put together tote bags of resources and warm meals and get them out to people. There was no hanging out, talking, laughing, but at least it was something. So that's really what we've been doing and will continue to do until it's safe to go back to that original format. Next slide, please. Yeah, and then just really briefly, Alan and I are both really lucky to have been a part of something called the Youth and Social Environment Lab at Berkeley, or the WISE Lab, under the direction of Dr. Colette Auerswald. So our lab has worked on several projects, one of which most recently we've been lucky to publish a paper called On the COVID-19 Frontline and Hurting, which really covers the needs of providers working with youth experiencing homelessness, what has been working, what has not, and what they really need in order to better succeed at serving this community in the midst of a tragic global pandemic. We are also working kind of as a sister project now on a youth needs assessment to look at the needs of youth experiencing homelessness in the midst of this pandemic. Dr. Auerswald is getting ready to lead the first ever course on homelessness as a breadth requirement at UC Berkeley, and one that's near and dear to my heart, which is allostatic load in youth experiencing homelessness, which is actually my honors thesis that I'm writing. And then finally, we have our Ending Youth Homelessness Catalyst group, where once a semester, we really try and bring together students, faculty, staff, and community partners to really discuss not only lived experiences of homelessness, but combine that sort of research and activism into one community-based effort. And then I will pass it over to Alan.
Great. So what are we talking about today? Like I said earlier, there's 3 things we're going to talk about. We're going to talk about gender and gender identity, and thinking really specifically about what that means, how it's constructed, what it sort of technically means. We're going to talk a little about youth homelessness. As Anika said, we're both focused, our work is focused a lot on youth homelessness. We're both a part of this WISE lab that's focused on addressing youth marginalization. And then I'm going to talk a little bit about serving transgender and non-binary people specifically in healthcare and homeless services. And so trying to give some sense of, as we've talked about these 2 things already, now what do we do about it? So thinking about gender, there's lots of different things out there in the world about what gender means. And I think that especially recently, there's been a lot of sort of transitions in ways that we think about gender and how different parts of gender have become more prominent. But it doesn't really often sort of seem clear what the sort of technical understanding of gender is. So a biologist and physician named John Money in 1955 actually sort of invented or came up with the original concept of gender. Previously, gender and sex were all sort of combined, and there wasn't really a clear sense of, is there any sort of different thing here? And according to Money, gender as a sort of broad concept is really comprised of these 6 things. So the sex that people were assigned at birth and how they were raised and how they were treated as they were being socialized, their external genitalia and body parts, the internal reproductive structures and systems that are going on, how hormones and other secondary sex characteristics have operated, what their gonadal sex is, and then what their chromosomal sex is. So Money actually, at the time, wasn't very well regarded in this work, but generally, actually, most of his work has kind of continued to be accurate and authentic to today. But when we think about all of these sort of different things, we're really thinking about a few things. So thinking about gender theory, or sort of how do we understand these things in culture or in kind of like more modern life, we go to Judith Butler, who in her 1992 book, Gender Trouble, she articulated that gender is comprised of these three things. So it's gender identity, gender performance, and what she referred to as anatomical sex. So gender identity is how we identify our gender in relation to the world around us, in relation to the cultures and the societies and the social groups that we're a part of. And gender identity is really this internal idea. It's how we identify inside in relation to these ideas. And that may or may not be something that we sort of publicly express, but that the identity formation itself is an internal process. And then gender performance or gender expression or gender presentation is how we demonstrate our gender, how you might see gender publicly when we're walking down the street and we see other people. The way that they're presenting their gender in the way that we can see it is gender performance. And then thinking about then how these things are associated with the sex that we're assigned, with the sort of ways that our bodies are constructed within societies, are assigned our social sex, and that's specifically how our bodies are interpreted by institutions of society. So let's talk a little bit about what is sex? What is the sex assignment? I think that we often think about sex as these things that come up sometimes, but actually are like a really integral part of how we operate in our lives. So when we get assigned a sex, it's a social construction, and that's something that I want to make sure that we're really clear about. That, you know, thinking back to John Money and how he has these 6 different understandings of what gender is, that many of those things are actually what we kind of think about medically or scientifically as sort of sex formations. But when we get assigned a sex, that almost always, maybe recently we're seeing some changes here, but it almost always either means male or female. And that assumption of male or female is really something that gets assigned to us. We pop out of a womb at some point, and once we come out of the womb, then a doctor then assigns us a sex based on their kind of assessment of what are these external body parts. There's not chromosomal testing done. There's not x-rays or ultrasounds of, I guess not x-rays, but there's not ultrasounds of people, of a baby's internal reproductive functions. And also we know that these things change over time. And that this assignment based on a baby's external genitalia then becomes our social sex. It gets put on our birth certificate with an M or an F, then that gets translated to our social security card when we go into medical and can sort of continue through our medical processes when we're young and sort of throughout our lives. In our medical records, we have an M or an F. When we start school, there's an M or an F. And that is never something that's ever actually sort of asked of the child. It's not something we ever really confirm. We just see, hey, you've got this tiny little body part on the outside. So now we're going to make this decision about your sort of social functioning for the rest of your life. So gender identity then is how our gender aligns with what are actually now pretty outdated social expectations for gender based on that sex assignment. So when we're talking about sex or sex assignment, we're talking about that social sex, that way that we get assigned this M or an F. And so how we understand ourselves internally in relation to our body and what's expected of our body is our gender identity. Cisgender then is when the sex you're assigned and your gender are aligned along these expectations. So if you are assigned male and you identify as a male, then that would be a cisgender person. Transgender then is when someone's gender, when their gender identity and how they understand themselves in relation to gender sort of cultural norms is not the same as what's expected of their assigned sex. So for example, a man who was assigned a female at birth would be a transgender man. And then non-binary gender identity is when your gender doesn't conform to a woman or man identity. And that is sometimes, but not always, sort of considered a transgender identity as well. But it's really something that's neither male nor female. So it's thinking about non-binary gender identity, it's when we don't necessarily specifically identify with man or as woman. People can refer to many different genders. It's non-binary gender identity is not just this sort of universal, every single person who's not identifying as a man or woman is therefore non-binary. There are a lot of genders associated with it, but non-binary is generally this umbrella term to say that you're not aligned with one or other of these two sort of binary expectations of man or woman. Some non-binary people do identify as transgender and some don't. So often when we're talking about non-binary identity, we use phrasing like transgender and non-binary people, because sometimes that includes both and sometimes that includes sort of separate groups of people. So when we're thinking about bodies, remember that when we're talking about assigned sex, when we're talking about sex assignment, that's really the sort of bodily function. And yet often when we think of bodies in terms of what's going on with them and trying to figure out, okay, we see this person, we're interacting with this person, so how do we understand their body? So a question that I have in this context is, when is it appropriate to ask an acquaintance or a stranger, or in our context of thinking about healthcare or service, when is it appropriate to ask a client or a patient whose care has nothing to do with their sex or reproductive functions about their bodies or discuss their bodies with other people? I think this is especially important as healthcare providers to think about, as particularly as sort of medical providers, we're interested in, we care about people's bodies, right? And so when we're curious, when those things come up, where we're like, oh, wow, this is a person whose body sort of operates in a different way than I might be expecting or might have experience with, and we might be curious about it. The answer is that it's never okay to talk about a person's body when it's not appropriate to talk about their body. If they're an acquaintance or a stranger, and when it's a client or it's a patient where you're not explicitly working on sort of gynecological care or other reproductive care, that's not something we should be talking about. Because gender, the way that we socially interact with people, is how we should be talking about people, is how we should be interacting with people. And that gender, as we've just been talking about, is only one part, a person's body is only one part of the way that they interact socially. And so in thinking more about this social interaction, when we're thinking about transgender people and thinking about how do we talk about people who identify as transgender, whose identities don't necessarily match what might be on paper or might be within the sex assignment, is we got to think about two really important things. The first thing is about names, and specifically this idea about a dead name. So when we're talking about transgender folks, a person's dead name is their assigned legal name that they're no longer using. Not all trans people have dead names, because not all trans people use different names than their assigned legal name. But for the most part, they do. And so we have to be really intentional in thinking about how do we use and when do we use a person's legal name or their dead name, and when do we use their actual name. And we have to be really clear in our understanding that using a person's dead name is always harmful. We'll talk a little bit more later about sort of best practices for these kind of things, but I just want to make it clear here that we always have to consider that a person's name that they identify to us is the name that we should be using. If we're seeing a name on paper, particularly a legal name on paper, then that's not necessarily the name that we should be using with the person. We should not assume or expect that because we see someone's legal name, that actually is the name that we should be using to refer to them. And then often we need to think, or then also we need to think about pronouns. We need to think about how pronouns are highly gendered. And thinking about how do we identify our pronouns, how do we sort of see what pronouns are, and understand that pronouns are not just these binary norms that we've been thinking about when we think about, many of us use he, him, or his, or she and her pronouns, but that those are not the only options. Many other people, many non-binary people especially, use pronouns such as they and them. And there's also a host of other pronouns as well that have been constructed and used to support non-binary people in sort of being treated in their sort of linguistically in a way that is affirming to them. So we're going to transition a little bit now to talk about youth homelessness. Once we get to the sort of third section of the talk, we'll be bringing the stuff more together. And I'm going to pass it over to Anika to tell us some more about youth homelessness.
Perfect. Thank you so much, Alan. I'm learning so much already. So yeah, just to give everyone just a brief, introduction. So young people ages 13 to 24 or 27, it's dependent on what definition you want to use, who live independently of caregivers and independently of social support, who are without stable or consistent residence, income, or access to the support and networks they would need to transition into stable and independent adulthood. That is what we consider youth homelessness. So going into further detail, as y'all can imagine, I'm sure there are many reasons for why an individual might become homeless. These can include family, poverty, mental health, unemployment. Some are more common reasons than others for youth experiencing homelessness. An important point we want to bring up is that the visibility of youth experiencing homelessness is often that youth are far less visible when they're experiencing homelessness than their adult counterparts. And just to briefly go into why that might be. Well, first of all, there's this idea of survival mechanisms. So for youth experiencing homelessness, one survival mechanism that they might have is to appear stereotypically housed, I'll say. So they might prioritize seeking out hygiene. They might prioritize doing their laundry. They might prioritize having a fresh set of clothes to wear, looking what we might consider stereotypically housed, as opposed to prioritizing seeking out a meal or shelter. And the reason why they do this is it's a survival strategy, that if they can appear to look less homeless, then they will be safer. Another reason that youth are often less visible when they're experiencing homelessness is that the way that they experience it is not necessarily what people might consider when they first consider street-facing homelessness, meaning that youth might be couch surfing, they might be living in their cars, hotels, doubled and tripled up with others. So all of these are forms of housing insecurity, but they're not necessarily what comes to people's minds when they think about homelessness. And so all of that can contribute to these experiences of victimization. And in fact, youth experiencing homelessness have some of the, if not the, highest rates of victimization, possibly amongst any known population group. There are several issues to how we define youth homelessness, starting off with the fact that the US Department of Housing and Urban Development, or HUD, well, they consider someone to be homeless if they are an adult, so over 18, and have some diagnosis of a disability or mental health condition. So this includes sleeping outside, it includes shelters, transitional and short-term programs, but as y'all can probably be thinking, it does not include youth at all. It does not include couch surfing, sleeping in cars or hotels. There is another definition from the US Department of Health and Human Services from their Family and Youth Services Bureau. And this one does include youth, and it does include families who are couch surfing individuals, people sleeping in cars and hotels, and people without diagnosed disabilities or mental health conditions. But there are still problems. So one of the things that's really important is to count our youth population who are experiencing homelessness. But these counts are really tricky. So one that some of y'all might be familiar with is the point in time count, or the PIT count. That count, though, is funded by HUD. And as we just said, HUD does not include youth in their definition of homelessness. And it's also fully based on who, quote unquote, looks homeless. As I just mentioned, that's incredibly problematic if we're going based on looks, considering that a lot of youth use it as a survival mechanism not to look homeless. So this count is incredibly inaccurate oftentimes. A better count is the Voices of Youth count, but the problem is that it's poorly funded, and its deployment is limited. And city and local estimates, which Alan and I can both tell you from working in homeless services in Berkeley, are usually quite awful because they're less rigorous and they're not held to quite as high standards. Yeah, and finally, just going into a little bit of who experiences homelessness and the disparities. So we know that 1 in 10 young people ages 13 to 25 are experiencing homelessness, which is quite tragic. And even up to 21% when you go to the category of ages 18 to 25. And like most health conditions, there are disparities amongst youth experiencing homelessness. It's not a blanket statement. It's based on race and education and disability, sexual orientation, gender identity. All of these things play an impact. We know that queer and transgender youth have and continue to be overrepresented in the population of youth experiencing homelessness, and that they're over 2 times as likely to experience homelessness in comparison to their cis-het counterparts. And that they're not only more likely to experience homelessness, but they're more likely to experience it for reasons of family violence and rejection. And once they are homeless, they are less likely to receive the adequate resources that they need as a result of stigma and discrimination from not only their peers, but from providers. And finally, just other things to keep in mind. In comparison to white and Asian youth, Black and Latinx youth are more likely to experience homelessness, as well as single or teen parents, youth who do not have their GED or a high school diploma, as well as disabled youth, youth with mental health conditions, and youth exiting systems such as the child welfare system or the juvenile justice system. And I'll pass it back over to Alan.
Great. So thinking more about health and the health of young people experiencing homelessness, because this group of young folks is so vulnerable to lack of support services, lack of connections to resources, they have extremely high rates of victimization, then we know they're going to have lots of prominent health needs. The most sort of important one is that there's a severe lack of access to services. Recent studies have found that 6 to 80% of young people experiencing homelessness have suggested they don't have access to health care at all, or they don't have health insurance. And by definition, as young people experiencing homelessness, they don't have adequate access to the resources they need to meet their basic needs, which is a fundamental sort of health need. If people don't have access to food and water and shelter and safety, then that's just sort of fundamentally an extreme sort of health issue. And then also, because of the trauma and because of the difficult experiences and victimization that young people experiencing homelessness do have as they're experiencing homelessness, we see high rates of substance use, we see high rates of sexual risk factors, and we see some pretty extreme mental health conditions, including up to about 86% or so of young people experiencing homelessness have identified some sort of mental health symptomatology. And when we're thinking about violence more specifically, violence is one of the most important sources of morbidity and mortality among young people experiencing homelessness. Young people experiencing homelessness, they experience high rates of abuse prior to entering homelessness. These rates are, as Anika mentioned, extremely high, particularly for queer and transgender youth who experience even more of this family violence prior to entering homelessness. And they experience high rates of assault, theft, structural violence, which is the deprivation of basic needs resources, and ongoing chronic harassment. And often people experiencing homelessness, particularly young people experiencing homelessness, are explicitly targeted for violence. There have been ongoing and unfortunately even growing instances of experiences of violence that specifically is targeting people experiencing homelessness for no other reason other than just that they are vulnerable targets to people who are sort of assumedly housed. So some of the things that lead to this violence against people experiencing homelessness is specifically about criminalization. So thinking about these laws that restrict where young people or people experiencing homelessness can spend time, things like sit and lie laws or anti-camping laws that prevent people from stopping on the sidewalk and sitting down on the sidewalk for any period of time, any sort of prohibitions against open containers or prohibitions against where you can have open fires or where you can have preparing food even, and then things like hostile architecture, or if we see, for example, like in public, if you see like a public bench that has like an armrest that's in the middle of the bench, so it makes it pretty much impossible to lay down across the bench, that would be an example of hostile architecture that really is designed to prevent people from being able to sleep, designed to prevent people from being able to really honestly sort of rest in public at any time. And these restrictions on sleep is a form of structural violence. It's a form of this violence that prevents people from being able to access sleep, which I think, as all of us know, as people connected to medical care, we understand that sleep is one of the most important things that the human body needs. And that it's not just that the sort of hostile architecture makes it difficult to sleep, but it's also that many of these laws about where you can and cannot be have to do with time of day, have to do with kind of where you are. And so what we've seen from a lot of our research is that people are interrupted by the police, they're harassed by the police in the middle of the night, or in situations where they're just really not able to get any sleep, which then leads to more long-term health conditions as well with this lack of sleep. And the issue with prevention and with violence prevention efforts is that the violence prevention efforts that have been designed for young people aren't explicitly designed to exclude young people experiencing homelessness, but sort of by their function are totally exclusive. These prevention efforts rely on community involvement. They rely on having a consistent or stable place to sleep. They rely on having consistent or stable and engaged social networks. And these are all things that young people experiencing homelessness don't have, sometimes by definition, don't even have. So we've articulated there's a lot of these really terrible things that are happening to transgender people, and then also specifically happening to people experiencing homelessness. And so talking about some of these issues in healthcare and social services specifically is that there's this systemic lack of affirming healthcare. The transgender people face overwhelming rates of victimization in their healthcare interactions. So in their interactions with their physicians, with their nursing staff, with other medical providers that they interact with. And there's been really, frankly, sort of traumatizing to read reports coming out for years about these extensive experiences of being denied services, being misgendered, being outed, how there's been inappropriate touching, inappropriate focus on the clinical interaction on their genitals or their transitioning experience. They've experienced verbal abuse and even physical and sexual abuse, literally at the hands of their healthcare providers. And that also there's systemic issues that lead to issues in getting appropriate and affirming healthcare. So insurance tends to not cover gender affirming treatment. And in order for insurance to often cover this treatment, there needs to be a diagnosis. And at this point, the diagnosis is a diagnosis of gender dysphoria. If you are interested in the sort of extensive history of sort of transgender identity diagnoses and sort of pathologization, I recommend going to look into that. But now where we are is we're talking about gender dysphoria, or this idea that our gender doesn't match, or our gender, it causes us stress is generally the idea of where the diagnosis is at this point. The problem is that requiring a diagnosis of gender dysphoria in order to get insurance coverage means that automatically creates a pre-existing condition, which currently in our healthcare system, we can't be discriminated against in receiving care or insurance because of pre-existing conditions. That's not always been the case, and who knows how long that will continue to be the case. But even in that sense, that means that that could affect the kinds of insurance that people can have access to and the sort of cost of insurance. And it also highlights those differences within medical records. If you look at somebody's medical record and there's no sort of indicator of any sort of gender or anything except they have a diagnosis of gender dysphoria, then this idea of requiring this diagnosis always sort of systemically outs trans people. So continuing this idea of these structural barriers to healthcare, in addition to the fact that just in general, health insurance doesn't always cover gender affirming care, health insurance or health records and health insurance are often sex essentializing, or sort of whatever your social sex is, this sex assignment that you have, this M or F, that is where a lot of decisions are made about how records are organized or how records are described and how clinical care is approached, and then how clinical care is reported and covered by health insurance. So that creates this double bind of the transgender experience in healthcare, where either the system keeps your dead name or legal name, doesn't have preferred pronouns, doesn't have your preferred name, and it sort of doesn't really allow one to have a transgender identity within their healthcare experience, which is, you know, on the one side, we want our health records to use the names that we want to be called. We want our health records to use the pronouns that we're using. We want our health records to really be true and authentic to us as individuals. But then what happens then is if that's the case, then what happens is that we have these issues of sort of appropriate care for people based on these sort of binary or sex essentialized medical norms. So if, for example, you're a transgender man who has worked to make sure that your health records indicate that you should be referred to with your man name and pronouns, then sometimes what that means is then you get treated as a man, which is what we should be doing, but that then leads to difficulties in accessing healthcare that's appropriate to one's body. So let's think about this, for example. So transgender men, so a transgender man is a man who was assigned female sex at birth. Generally, that means that that man has sort of what we would call female, quote unquote, reproductive organs. So they often will have a uterus and ovaries and will have periods, and therefore need to get the kind of care that somebody who has those reproductive organs needs. So they need pap smears on a regular basis. They might need hysterectomies at some point in their lives. They need the kind of care that we might refer to as women's health, or they might need the kind of care that gets sort of plugged into the system as being for women only. So when a transgender man goes in to get a pap smear, then there's huge rates. I think that this Qatari article says that something like 75% of the men in the study identified that they couldn't even get coverage, or they had to sort of push back about their coverage getting denied for a pap smear, because pap smears are for quote unquote for women, according to this insurance system and according to our sort of how our health clinical interactions work. And so because this person's a man, then they get rejected, because it's like, well, you can't get a pap smear, you can't get a hysterectomy because you're a man, that's only for women. And so then because the system is identifying them as a man, which it should be doing, then they're getting rejected from getting the sort of appropriate and affirming care that they need. And this is actually already after a transgender man is already facing all of these barriers. They have to show up at a clinic that says a women's health clinic. They have to deal with the sort of stigma of being a man within a women's health space. They have to deal with making sure that the system is appropriately reporting their name and pronouns, that the clinic staff are doing that, and the clinic staff are being affirming, and the clinic staff are treating them respectfully as a man, and also affirming their body parts and making sure they're getting the appropriate healthcare for their body parts. And then after all of that, which is already a stressful situation, then they get to the situation where then their insurance company says, well, we're not going to cover that because you're a man and that's only for women. So these barriers often extend in different ways to thinking about services for people experiencing homelessness or other social services. There are many services that are sex or gender specific. So thinking about women's shelters, particularly in the context of intimate partner violence, for the vast majority of intimate partner violence related services are specifically for women. And the way that we think about women is often an issue too, because then there's this issue of, when we're talking about women's shelters, when we're talking about women's health, does that mean people who identify as women, which would include trans women? Or does that mean people who are assigned female, which should include trans men? And how do we think about that? And that leads to all this stigma, particularly if you're thinking about, okay, you have a women's shelter, and does that mean then that transgender women are going to be accepted? The current, thank God for not much longer, but the current Secretary of HUD, Ben Carson, if you have heard about any of it, has spent a lot of time trying to make sure that HUD shelters, so the largest federally funded housing support organization department in the country, he has been trying to make it so that shelters are sex specific as opposed to gender specific, which would mean that transgender women would be placed in men's shelters, which not only is just traumatizing by its own sense of not being affirming to their gender, but also that places them at huge risk for violence. Transgender women experience huge rates of violence, whether in placed in sex-specific or male sex-specific services. There's lots of stigma, even if the services are sort of allow for people based on their gender or sex to show up. There's lots of transphobic stigma and homophobic stigma. Many service organizations are faith-based, which often rely on outdated gender binary enforcing norms, often are really shaming and stigmatizing of queer and trans people. Even if we're thinking about just like uninformed providers, there are a lot of providers that don't know about gender, they don't know about transgender people's experiences, and that often they experience issues in receiving the services they need just because the providers are just uninformed, not even if they're necessarily trying to be harmful. So thinking about what are some of the best practices for affirming trans and non-binary people in care, and this is in healthcare and also in social service. So the first thing is always ask for name and pronouns and share your own name and pronouns. Modeling how this is a standard practice that we should all be doing. Ensure that the documentation that your services have and the records that you have separate entries for what is a person's assigned sex and what is their sort of legal name, and then what are the names that they're using. Because so much of the healthcare and because so much of social services is actually connected to a person's sort of official identity and requires things like checking health insurance or social security, whatever's, or getting IDs, then it's entirely possible that you have to have access to their legal name and you have to ask their legal name, but making sure that you only use their appropriate names and pronouns at all times, that you don't have to explicitly be using their legal name. Making sure to always maintain confidentiality, never outing people to other clients or even to other staff who aren't directly involved in care. There's one of the things when we were talking earlier about these victimization experiences of healthcare is that in these moments where healthcare providers do interact with a trans person, we see a lot of the issues is that they then go and tell all of their sort of colleagues, and so then they're outing this person to people who really it's actually none of their business. Providing gender neutral options, including restrooms, but also making sure that there's really no situation in which a service or a system is gendered when it doesn't explicitly need to be. And I actually encourage all of us to think about, when do we need to gender services? And frankly, I don't think we ever need to. But thinking about, as much as possible, providing these services that are gender neutral, that don't require somebody to explicitly identify as man or woman, and then therefore lead to issues of being gender policed. It's important to never ask about a person's body parts or their medical transition unless it is explicitly necessary for providing care to them. And also, you should be clear as to why you're asking. This is particularly important as healthcare providers in healthcare interactions, when there is this historic sort of fetishization or tokenization of people by medical providers who are curious and not necessarily trying to cause harm, but are causing harm by unnecessarily asking about private, personal things. Making sure that that your clinical practices or your service practices focus on a person's medical and anatomical function rather on their gendered assumptions. So this is thinking about, if a man comes into your practice and says, hey, I need to get a pap smear and I need to maybe think about an IUD or something, then that your response should be, cool, let's talk about that. Let's talk about, what are the sort of parts of your body that need that kind of care, and not saying, oh, why would you need that? You're a man. Like, what do you don't need a pap smear. You don't need an IUD, you're a man. But really thinking about what is a person's body, focusing on that actual person's actual body, and not thinking about what do you expect from somebody's body based on how you are seeing their gender. And then the last one and the most important one, honestly, is really just keeping yourself and your colleagues updated, paying attention to what is the emerging information and research and best practice coming out about medical practice with transgender people, and keeping yourself informed, keeping yourself updated. Some of the other research about these victimization experiences that trans people have had is that they've been interacting with healthcare providers who are citing medical practices or protocols that are old and outdated and actually harmful. And so continuing to be updated, continuing to make sure that you're learning about best practices, and also being sure that you're presenting yourself really authentically. So if it's something that you have a transgender patient in your office and you don't have an answer to a question they have, or you don't necessarily know what the best practice is in certain medical situations, then saying that up front and saying, you know, I don't know, let me go do some research and make sure that I do that correctly. And so being clear about where your knowledge is and getting more knowledge, not asking the patient or the client to be the one educating you, but educating yourself on these best practices. Cool. So that's the end of the formal presentation. So we wanted to open up for questions. Looks like we have like 12 minutes or so. There were questions that folks submitted in advance. So we do have some questions that we're prepared to answer if no one wants to speak up right away, but we don't have to get to those. I want to open it up to your questions, and feel free to ask any questions of me about the stuff we've talked about. If you have any questions specifically for Anika about Suitcase Clinic or other things that she talked about, we can ask her too. So let's open it up.
Yeah, Alan, I actually got a question message to me in the chat that
Awesome.
I briefly answered, but I think would be awesome maybe if we could just chat about in a little more detail for everyone. So Cheyenne asked me, I hope it's okay. I'm so sorry. I realized you privately messaged me that. Okay. Cheyenne asked me, I'm wondering how teens under 18 are homeless and not under the care of CPS. Is it a decision made by the teen? Which I think is a great question.
That's a really good question. And that actually technically, or is the sort of technical reason why HUD excludes young people from their definition, because according to HUD, their response is, oh, young people should either be in child welfare or be with their families and their legal guardians. And so there are no homeless young people. So the reason why they're not in CPS is, there's a few reasons. I think part of it is that, well, the first thing is that like child welfare has historically also been unsafe for trans and queer and even just young people who are in situations that lead to them being homeless. And so, you know, as much as I, as a social worker, really desperately want child welfare to be this amazing system, it's not necessarily always, and it can often be unsafe. So we do see young people who do get put in child welfare that then leave sort of without sort of consent of the system. They run away, or they just don't you know, participate in their system stuff. Specifically for queer and trans young people, because child welfare can often be unsafe for them, that's another reason why we probably see higher rates of queer and trans young people being overrepresented in populations of young people experiencing homelessness. The other thing too is that, you know, I think that like when we think about CPS, we think sort of really technically about how CPS is like, you know, once you get to this age, whatever, then you're gonna, you know, age out. Once you get to age 18, then you age out, and before age 18, then like everyone gets included. But the fact of the matter is that in real life, if you're a 16-year-old who's on the street and a social worker's like, hey, you're 16, you're a minor, you should be in child welfare, they're not going to really do anything. I mean, a 16-year-old is going to be pretty much ignored. They're only going to be in the system for 2 years, and child welfare workers have overburdened caseloads. I was a street-based social worker doing street-based outreach with young people for a long time. And when we were interacting with a young person who was 15 or 16, we would offer or ask if they wanted to be connected to child welfare services. But for the most part, they would not have participated. They didn't participate when we tried to get them to. And for the most part, it's because those services seem to be unsafe for them.
Yeah, there are a couple more great questions in the chat. I'll just read them out to you, Alan. So the first one was, because so many young unhoused folks try to mask their homelessness, does it also mean that they're often less willing to accept assistance too? I'll just speak to that really briefly and say that in my own personal experiences working with youth experiencing homelessness, yes. Oftentimes the way that we have to approach services for youth experiencing homelessness can be just different. Like I said earlier, there's just not a one-size-fits-all blanket statement as to how people experience homelessness. And so that means that the services that we provide when trying to assist folks in that situation have to be case dependent and specific. So yes, oftentimes youth just appreciate being approached in a different way and asked. The best thing to do that I found, just this is only based on my experience, is just to ask someone, how can I best support you, right? So it's just giving people the opportunity to tell you what they most need, not assuming you know what they most need. And so I'll just share just like a brief little story, just a really short one, but just even something as basic as, what people refer to as panhandling, or just people spanging and asking for extra change. If you go up to someone and you go into a restaurant and you come out and you see someone on the street and you just hand them food and you go, here you go, right? Because you assume like any food will help them. That's really just taking away from their free choice. What if they're allergic to something? What if they don't like something? It's so much better. And this is just an analogy to say, it's so much better to just ask someone, how can I support you? Or what would you most like? Instead of assuming that anything you do for them is going to help. And I just like to tell that story because I think it's really similar to when we approach just working with anyone experiencing homelessness, and to say, what can I do to support you? And what would you like? But I don't know if Alan wanted to share anything else.
I think that was like super spot on. I appreciate the example. Totally. Yeah, that's took the words out of my mouth. I think the thing that I would add is that because systems can be very paternalizing and sort of say, this is what you need to young people, that, doesn't like, here's the food, like without asking them, like, what kind of food do you want? Or are you allergic to anything? But just like, here, you have to eat this. And if you don't, then you don't deserve services. That leads to young people being very suspicious, being very wary of being connected to services. So that's another reason this sort of continued pattern of doing that kind of behavior that Anika talked about is why we see people really resistant to receiving services as well.
A couple more questions. So another question being, when/how is the best way to ask about pronoun preference for a patient? Sometimes names are hard to assess in terms of what pronouns are preferred.
Yeah, I think you should always just ask right away. And if you're talking about patients specifically, that for me means that they've probably done some sort of intake, or you need to do some sort of intake or sort of opening of just sort of introducing, and just starting right away with, can you tell me your name? And can you tell me, or like, what name should I call you? And what pronouns do you want me to use? And keeping that really consistent across everything. It's like if someone shows up to your practice and that person's name is Mike and they look like what you'd assume a man looks like, and you just sort of don't think you need to, that's an assumption that might actually be harmful to somebody. So asking everybody, what name should I call you and which pronouns do you use, is the best way to do it, and starting it out and also modeling it. So saying, when you introduce yourself to a patient for the first time or otherwise, saying, my name is Alan, I use he, him, his pronouns. What's your name? Or what name should I call you? What pronouns do you use? And sort of continuing on with your sort of clinical interaction. But really immediately, as soon as you meet the person, introducing yourself with your pronouns and asking them what they want to be called and which pronouns they want you to be using.
Great. And then I know we only have a few more minutes, but there's one more question. Do you see insurance companies shifting towards more diverse coverage to accommodate for individuals that are transgender?
I mean, yes. I don't know. I haven't seen any sort of like specific research about that more broadly. I think it depends on where you are and which company it is. I know Kaiser has been doing a lot of work to be more affirming and to build in better practices. Kaiser makes it easier though, because of Kaiser's model of being sort of both the insurance and the provider kind of thing. And also there's lots of health insurance companies across the country and even worldwide. And so I think that you might see those insurance companies getting a little bit better, particularly if they cover larger sort of urban areas or larger urban areas that might be sort of quote unquote more progressive. So like sort of yes, but to the point where it still is a huge issue.
Hey, Alan, could you actually answer my question about how like the age of providers might affect the kind of service that transgender and just, and broadly LGBTQ plus individuals receive? Are younger, you know, practitioners a little bit more open-minded, and how does that affect the caregiving?
Yeah, that's a great question. So, and it's one that I appreciate because I think that it sort of highlights that I think we often think that that age, that sort of younger, newer, fresher providers are going to be sort of more competent. They might be more aware. They might be more open to learning more. Um, I haven't seen any sort of research about it. To be honest, most of the research is really just figuring out what are providers even doing. We have some of this recent stuff, but the age has not been something that I've seen sort of explicitly looked at or thought about. I think it's less about age, and I think it's more about education, and specifically sort of what educational environment someone's being trained in, and how that educational environment sort of pushes them to think about these ideas and thinking about sort of sex essentialized program or practices as opposed to sort of anatomically appropriate practices. I think in general, we're going to see that younger people are going to be more open to this. And so we might see that younger providers might be more open or competent. But I know quite a few quite old providers who are some of the best providers that I've seen working with trans folks. And I've seen a lot of young folks who are recent graduates, or not even that recent, medical providers who are pretty awful. I think that one of the things about age that we need to be really aware of is that the age is this sort of, these developmental functions that are happening in our brains through our 20s and late 20s, even into our 30s, about our neurological functioning. I think a lot of younger providers are more, frankly, arrogant. I think that they think that they have the right answer. I think that they're also less confident in their interactions. I think confidence in interactions is something that we do see a lot as an important component to affirming practice, is that when providers feel less confident, when they are less experienced, then they're going to be sort of more by the book rather than being person-centered and person-engaged. We might see them, if they did go through a training process that was not very sort of gender expansive or inclusive, they might rely back on what did I learn in school, and what they learned in school might be actually harmful. And so I think that we also can see this, the longer you've been in practice, the more confident you are in your practice and the more able you are to really focus on this person-centered engagement. I think that also actually increases the affirmation of practice as well.
Awesome. Thank you so much. With that, it is 1 o'clock. I know a lot of people have to get to class, meetings, Zoom sessions. So I want to say thank you again so much to Anika and to Alan for, spending the lunch hour with us to get this all done. I think, the social aspect of healthcare is not taught very well in any school. Granted, I'm still a master's student. I'm not in medical school yet, but appreciate your guys' input so much. And I look forward to learning more from both of you in the future.
Yeah, thank you so much for inviting us. Thank you, Anika, so much for being a great partner in this presentation. And
thank you, Alan.
And I hope you all stay well in this difficult environment.
This was really informative. Thank you.
Thank you so much for being here. Bye. Take care.
Thank you guys. And I recorded everything, and I'll send you guys a recording as well. And then do you guys mind if I post this on YouTube or anything like that?